Proton pump inhibitors, omeprazole, pantoprazole, esomeprazole, lansoprazole, are among the most prescribed medications on Earth. Over 15 million Americans take them daily. Hundreds of millions more use them worldwide. Many have been on them for years, some for decades, without a single conversation about what chronic acid suppression is quietly doing to their skeleton. Here is what that conversation should sound like. Long-term PPI use doesn't just suppress stomach acid. It disrupts the biochemical environment your gut needs to absorb calcium, impairs the hormonal signaling that governs bone remodeling, and, according to multiple large-scale epidemiological studies and meta-analyses, measurably increases the risk of hip, vertebral, and wrist fractures. This is not a fringe hypothesis. This is a mechanism-supported, clinically documented, FDA-acknowledged risk that most patients on long-term PPIs have never been told about. Today, we trace the entire pathway, from the proton pump in your stomach lining, to the osteoclast on your bone surface, to the fracture risk on your DEXA scan. Every step, every mechanism, every piece of evidence. Let's decode it. What PPIs do. The mechanism of acid suppression. To understand the skeletal consequences, you first need to understand exactly what proton pump inhibitors do at the molecular level, because the damage is a direct downstream consequence of their mechanism of action. Your stomach lining contains specialized cells called parietal cells. These cells express a membrane enzyme called the H+, K+ ATPase, the proton pump, which actively secretes hydrogen ions, H+, into the gastric lumen in exchange for potassium ions, K+, generating the highly acidic environment of a healthy stomach, a pH of approximately 1.5 to 3.5. PPIs are irreversible proton pump inhibitors. They are prodrugs, taken orally, absorbed in the small intestine, and then selectively concentrated in the acidic environment of parietal cell secretory canaliculi. There, they are activated by acid into their sulfonamide form, which covalently binds, irreversibly, to cysteine residues on the H+, K+ ATPase, permanently disabling that pump. Because the binding is irreversible, the effect persists until new proton pumps are synthesized, a process that takes approximately 18 to 24 hours per cell cycle. This is why PPIs are dosed once daily and why acid suppression builds over 3 to 5 days of continuous use. When functioning properly, PPIs raise intragastric pH from its natural 1.5 to 3.5 range to between 4 and 7, sometimes higher with higher doses. For managing erosive esophagitis, Barrett's esophagus, H. pylori eradication, and Zollinger-Ellison syndrome, this profound acid suppression is clinically appropriate and life-changing. The problem arises when this gastric pH manipulation becomes chronic, sustained over months to years, in millions of patients for whom initial prescriptions were intended for short-term use, but who were never taken off. Because gastric acid is not merely a digestive convenience. It is a fundamental requirement for the absorption of several nutrients critical to skeletal health, and when it is chronically suppressed, the gut-bone axis begins to fail silently. The calcium absorption crisis, acid, solubility, and the gut-bone axis. The first and most direct skeletal consequence of chronic PPI use is impaired calcium absorption, and to understand why, you need to understand calcium chemistry. The most abundant dietary form of calcium, and the form found in most supplements and fortified foods, is calcium carbonate. Calcium carbonate is insoluble at neutral pH. It requires an acidic environment to dissociate into its bioavailable ionic form, Ca². In a normal stomach with a pH of 1.5 to 3.5, calcium carbonate dissolves efficiently, releasing Ca² ions that are then absorbed in the duodenum and proximal jejunum via two mechanisms: a transcellular active transport pathway mediated by the TRPV6 calcium channel and calbindin D9K, regulated by calcitriol, and a paracellular passive pathway driven by concentration gradients. When intragastric pH is chronically elevated to 4 to 7 by PPI therapy, calcium carbonate solubility is dramatically reduced. Less Ca² is released. Less Ca² reaches the duodenal absorptive surface. The transporter pathway operates on a substrate that isn't adequately supplied. A pharmacokinetic study published in the American Journal of Medicine by O'Connell et al. Directly demonstrated that omeprazole use significantly reduced calcium carbonate absorption, measured by radiolabeled calcium absorption testing, while calcium citrate absorption was relatively unaffected because citrate salt is already in a more soluble ionized form and is less pH dependent. This has a direct clinical implication. patients on long-term PPIs who are supplementing with calcium carbonate may be absorbing substantially less than they believe, while the same individuals taking calcium citrate maintain more reliable absorption. Beyond direct calcium malabsorption, chronic acid suppression affects vitamin B12 absorption. B12 requires acid-mediated cleavage from dietary protein, and magnesium absorption in the small intestine. Since magnesium is an essential cofactor for both vitamin D activation and parathyroid hormone function, this creates a compounding cascade of nutrient deficiencies converging on bone. A landmark study published in JAMA Internal Medicine identified hypomagnesemia, low serum magnesium, as a clinically significant consequence of long-term PPI use, occurring in a subset of patients on prolonged therapy and resolving upon PPI discontinuation. The gut-bone axis is breaking down. Calcium is not getting in. The system is about to compensate, and the compensation is what destroys bone. The hormonal compensation, PTH, osteoclasts, and silent bone resorption. Your body defends blood calcium levels with extraordinary precision, because calcium is not merely a structural mineral. It is the electrical currency of your nervous system, the trigger of every muscle contraction, and the second messenger of hundreds of cellular signaling events. Serum calcium is maintained within a narrow range of approximately 8.5 to 10.5 mg per deciliter through a tightly regulated feedback loop involving two hormones, parathyroid hormone, PTH, and calcitriol, the active form of vitamin D. When intestinal calcium absorption falls, as it does chronically in PPI users, serum calcium begins to drift downward. The parathyroid glands, acting through calcium-sensing receptors on their surface, detect this decline and respond by secreting PTH. PTH does three things simultaneously. First, it signals the kidneys to increase calcium reabsorption from the glomerular filtrate, reducing urinary losses. Second, it stimulates the kidneys to upregulate 27 billion cypriot pounds 1, the 1-alpha hydroxylase enzyme, converting more 25-O-D to active calcitriol, which in turn increases intestinal calcium transport. A compensatory loop. Third, and this is where bone is destroyed, PTH directly activates osteoclasts, the bone-resorbing cells of the skeletal remodeling cycle. Osteoclasts work by acidifying the space between their ruffled border and the bone surface to a pH of approximately 4.5, using their own proton pumps, ironically, a related V-type H+ ATPase, to dissolve the hydroxyapatite mineral matrix of bone and release stored calcium into the bloodstream. In short-term calcium emergencies, this is appropriate and reversible. But when intragastric acid suppression chronically reduces calcium bioavailability, PTH remains persistently elevated, a state called secondary hyperparathyroidism, and osteoclast activity is chronically stimulated. The net result is continuous, low-grade bone resorption, calcium being drawn out of the skeleton to maintain blood levels, without adequate replacement through dietary absorption. Several studies have documented elevated PTH and elevated markers of bone resorption, including serum C-terminal telopeptide, CTX, and urinary N-telopeptide, NTX, in long-term PPI users, directly confirming that bone turnover is skewed toward resorption in this population. A study published in the Journal of Bone and Mineral Research by Yang et al. Found that PPI users had significantly higher serum PTH and lower bone mineral density at the femoral neck compared to non-users, an association that strengthened with duration of use. The skeleton is being taxed as a calcium reservoir for a gut that can no longer absorb calcium efficiently. And the longer this continues, the more bone mineral density is lost, silently, invisibly, with no symptoms until the fracture happens. The epidemiological evidence, fractures, meta-analyses, and the FDA warning. The biochemical pathway is mechanistically coherent. But science demands evidence at the population level, and it exists, in abundance. The landmark meta-analyses, a comprehensive meta-analysis published in Archives of Internal Medicine by Yu et al., analyzing 11 observational studies covering over 220,000 fracture cases, found that PPI use was associated with a statistically significant 26% increased risk of hip fracture, a 58% increased risk of vertebral fracture, and a 33% increased risk of any fracture compared to non-users. A subsequent meta-analysis published in Osteoporosis International by Kwok et al., analyzing 18 studies with a combined patient population exceeding 240,000, confirmed these findings, an overall fracture relative risk of 1.20 to 1.40 across fracture sites, with risk increasing with longer duration of PPI use and higher dose. The GPRD cohort study, a pivotal UK general practice research database study by Young et al., published in JAMA, analyzing over 13,000 hip fracture cases matched with more than 135,000 controls, found that long-term PPI use, more than 1 year, was associated with a 44% increased risk of hip fracture. The risk was dose-dependent. High-dose PPI use conferred a 2.65-fold increased risk of hip fracture. This dose-response relationship is critical. It is one of the Bradford-Hill criteria for causation. The fact that greater exposure produces greater harm supports a causal rather than merely associational interpretation. The FDA response. In May 2010, the U.S. Food and Drug Administration issued a drug safety communication on prescription PPI labels, requiring updated warnings about the potential increased risk of fractures of the hip, wrist, and spine. In 2011, this warning was extended to over-the-counter PPI products. The FDA communication specifically stated that the greatest fracture risk was observed in patients receiving high doses or on long-term therapy, defined as 1 year or more. This is not a theoretical concern. This is a federal regulatory acknowledgement of a documented harm, embedded in the prescribing information of every PPI on the market. Important nuance. It should be noted that most studies in this area are observational and residual confounding. The possibility that PPI users have underlying conditions that independently increase fracture risk remains a legitimate methodological concern. However, the biological plausibility of the mechanism, the dose-response relationship, the consistency across multiple independent datasets across different populations, and the FDA's formal recognition collectively constitute a compelling and clinically actionable evidence base. Additional skeletal mechanisms: gastrin, histamine, and osteoblast suppression. Beyond the calcium absorption and PTH-mediated osteoclast activation pathway, there are additional mechanisms by which chronic PPI use may impair bone formation, and they involve the gut-bone hormonal axis at a deeper level. Hypergastrinemia. When gastric acid is chronically suppressed, the feedback inhibition of gastrin, a hormone produced by G cells in the stomach antrum that stimulates acid secretion, is removed. In the absence of acid, gastrin secretion rises, a state called hypergastrinemia. Gastrin receptors have been identified on osteoblasts, the bone-building cells responsible for new bone matrix synthesis and mineralization. Research published in Gastroenterology demonstrated that chronic hypergastrinemia, experimentally induced in animal models, was associated with reduced osteoblast activity and impaired bone formation, independent of calcium absorption changes. This represents a direct hormonal pathway from PPI-induced gastric pH elevation to suppressed bone formation, not just increased resorption. Enterochromaffin-like cell hyperplasia and chromogranin A. Chronic gastrin elevation also stimulates enterochromaffin-like ECL cells in the stomach to proliferate, a condition called ECL cell hyperplasia, and to secrete increased amounts of chromogranin A. Elevated chromogranin A has been associated, in research models, with altered bone turnover markers, though the direct clinical significance in PPI users remains an area of active investigation. The net effect: PPI-induced skeletal harm operates through at least 3 converging pathways: impaired calcium solubilization, right pointing arrow, reduced intestinal calcium absorption. Compensatory secondary hyperparathyroidism, right pointing arrow, chronic osteoclast activation, right pointing arrow, bone resorption. Hypergastrinemia mediated, right pointing arrow, osteoblast suppression, right pointing arrow, impaired bone formation. The result is a double-sided attack on bone mineral density: more bone being resorbed, less bone being built. This is the biochemical definition of a skeletal crisis, and it develops silently over years. Clinical implications. Who is at highest risk and what should be done? So who is most vulnerable, and what does the evidence support in terms of clinical management? Highest risk populations. Postmenopausal women are at the greatest risk, because estrogen withdrawal already accelerates bone resorption post-menopause, and PPI-induced secondary hyperparathyroidism compounds this independently. The combination can dramatically accelerate bone mineral density loss in a population already on a trajectory toward osteoporosis. Older adults over 65 have reduced baseline calcium absorption due to age-related decline in TRPV6 transporter activity and vitamin D conversion efficiency, making PPI-induced further impairment proportionally more damaging. Patients on corticosteroids face compounding skeletal risk, since glucocorticoids independently suppress osteoblast activity and intestinal calcium absorption through distinct mechanisms. Patients with pre-existing low bone mineral density, Osteopenia or osteoporosis on DEXA should be considered high risk for PPI-associated fracture and warrant particularly careful prescribing review. Clinical management recommendations. First, reassess the indication. The most important intervention is pharmacological stewardship. A significant proportion of long-term PPI users no longer have a compelling clinical indication. They were started for symptom management and never reassessed. Current guidelines from the American Gastroenterological Association support periodic reassessment and step-down therapy, attempting dose reduction or H2 blocker substitution in patients without ongoing high-risk indications such as Barrett's esophagus, severe erosive esophagitis, or NSAID-associated gastric protection in high-risk patients. Second, switch calcium supplementation. Patients on long-term PPIs who require calcium supplementation should use calcium citrate rather than calcium carbonate, because citrate salt dissolves independently of gastric pH and maintains consistent absorption in chlorhydric conditions. This is a simple, evidence-supported switch that directly addresses the primary absorption mechanism. Third, monitor and optimize vitamin D and magnesium. Serum 25O-D should be maintained above 40 nanograms per milliliter, sufficient to maximize calcitriol-driven TRPV6 expression and intestinal calcium transport. RBC magnesium should be assessed and corrected, given the documented risk of PPI-associated hypomagnesemia impairing PTH function and vitamin D activation. Fourth, baseline and follow-up DEXA scanning. Patients on PPIs for more than 1 year, particularly postmenopausal women and men over 65, should have dual-energy X-ray absorptiometry, DEXA, scanning to establish bone mineral density baseline and monitor for progressive loss. This is especially important when other fracture risk factors are present. Fifth, fall and fracture risk assessment. Standard fracture risk calculators, including the FRAX tool developed by the WHO, should incorporate PPI use as an additional risk modifier, alongside age, sex, BMI, prior fracture history, corticosteroid use, and smoking status. Proton pump inhibitors are valuable medicines. For the right indication, for the right duration, they prevent serious esophageal disease and protect patients on chronic NSAIDs from life-threatening GI bleeds. But long-term, unreflective use, in tens of millions of patients who were never reassessed, carries a documented, mechanism-supported, FDA-acknowledged skeletal cost: impaired calcium absorption, secondary hyperparathyroidism, chronic osteoclast activation, and immeasurably elevated fracture risk that accumulates silently over years. The pathway is clear, the evidence is robust. The clinical response, periodic reassessment, appropriate supplementation, bone density monitoring, is straightforward. What's missing is the conversation. And now you have the science to start it. Subscribe if this level of depth is what you're looking for. We decode the evidence behind the medications, the mechanisms, and the outcomes that matter to your long-term health. See you in the next one.